Hi, everybody. I'm Kiara, a psychiatric mental health nurse practitioner, and welcome back to Tuesday Talks, where we break down psychiatry, clinical reasoning, and things you actually need to think about when assessing your patients. Today, we're talking about medical conditions that can mimic psychiatric illness, because not every patient who looks psychiatric actually has a primary psychiatric disorder. And this is where your differential diagnosis matters. Before you diagnose depression, anxiety, bipolar disorder, or psychosis, you need to ask yourself, could something medical be causing this? Because the brain is part of the body. And when something is going on medically, psychiatric symptoms can sometimes be the first thing we notice. Let's start with thyroid disease. Hyperthyroidism can look a lot like anxiety. You may see restlessness, irritability, insomnia, tremors, palpitations, weight loss, and even symptoms that sound like panic attacks. On the other hand, hypothyroidism can look like depression. Patients may experience fatigue, low mood, slow thinking, difficulty concentrating, memory complaints, and decreased motivation. So, before assuming everything is psychiatric, sometimes something as simple as checking thyroid function can completely change your differential. Next, vitamin and nutritional deficiencies. Vitamin B12 deficiency, for example, can cause cognitive changes, depression, irritability, confusion, neurologic symptoms, and in severe cases, even cause psychotic symptoms. And that's why the physical and lab portions of your assessment matter. Now, let's talk about delirium. This one is extremely important. If someone suddenly develops confusion, agitation, hallucinations, disorganized behavior, or changes in cognition, especially if their attention and awareness fluctuate throughout the day, don't immediately assume it's a primary psychotic disorder. Ask, could this be delirium? Infection, medications, metabolic abnormalities, hypoxia, intoxication, withdrawal, and other medical illnesses can all cause delirium. The key here is often the acute onset, fluctuating course, and impaired attention and awareness. And don't forget substances and medications. Stimulants can produce paranoia and psychosis. Corticosteroids can cause mood symptoms, mania, or psychosis. Alcohol withdrawal can cause severe anxiety, agitation, hallucinations, and seizures. Benzodiazepine withdrawal can do the same thing. Even prescribed medications can contribute to behavioral or cognitive changes. So, your medication reconciliation and substance use history are not optional pieces of the psychiatric evaluation. Neurologic disorders are another big category here. Seizure disorders, particularly temporal lobe epilepsy, brain tumors, strokes, neurodegenerative diseases, and other neurological conditions, can sometimes present behavioral, cognitive, or psychiatric symptoms. If the presentation is unusual, sudden, associated with focal neurologic findings, or doesn't quite fit the diagnosis you're considering, widen that differential again. Then we have autoimmune and inflammatory conditions. Autoimmune encephalitis is an important example. Someone can develop rapid behavioral changes, psychosis, cognitive changes, seizures, abnormal movements, autonomic instability, or catatonia. That is not the patient you want to label with primary psychotic disorder. And stop investigating. Sleep disorders matter too. Severe sleep deprivation and conditions like obstructive sleep apnea can contribute to irritability, poor concentration, memory problems, anxiety, and depressive symptoms. Sometimes the patient telling you they can't focus doesn't automatically mean ADHD. You have to figure out why they can't focus. And finally, think about metabolic and systemic illnesses. Electrolyte disturbances, hypoglycemia, hepatic or renal dysfunction, infections, and other systemic illnesses can all affect cognition, mood, and behavior. So here's the clinical pearl I want you to remember. New psychiatric symptoms, atypical presentation, and abrupt change from your baseline widen your differential. And new onset psychiatric symptoms later in life, especially without a previous psychiatric history, should make you even more suspicious of an underlying medical neurologic cause. This doesn't mean every psychiatric patient needs every lab or imaging study imaginable. It means your history, physical findings, medication, And substance review, age, timeline, and clinical presentation should guide the workup, because good psychiatric assessment isn't just asking which diagnosis fits these symptoms. It's also asking what else could these symptoms be. I'm Kiara, and this has been Tuesday Talks with Psychiatry with Kiara. Remember, before you diagnose the mind, don't forget to assess the body. I'll see you next Tuesday. Peace.